Welcome, everyone, to our program today. I'm Roy Herbst from Yale Cancer Center, and along with my co-moderator, Horst Borgay from Fox Chase, we have an amazing panel put together today to talk about the impact of COVID on the treatment of patients with cancer. This town hall is our second that we've done in this series. Thank you to Axiom for arranging this. And we're calling this COVID-19 and the impact on cancer patients. We've prepared a panel, in short notice, an amazing panel from all over the world to work with us today. We're going to have a number of different sections, and after we complete those sections where everyone will speak for about 5 minutes or so, we'll then have questions. Many of you are familiar with Zoom. If you didn't know Zoom a month ago, you're now probably very familiar with it. Zoom is going to allow us to have a chat box and question and answers. And if you go out and look at your, you see there's a Q&A box. So you can actually, in the Q&A box, ask questions. And that's probably the best way, given that looking at this now, we have over 200 participants and the number keeps going up every minute. It would be best to put your questions in the Q&A box. And Dr. Borgay or I or one of the other panelists will try to answer the questions. We're going to have 3 main areas of discussion. The first is going to be practice management. How do you visit and see your patients during these very tough times? And we have 2 experts on this who have been doing it for a long time, even before COVID, so they were really prepared. And we're going to hear about patient care strategies. We're going to hear a little bit about ICU. That was the topic of a meeting I just finished with Yale. Breast, melanoma, lung, head and neck. Then we're going to do a little bit of a trip to Europe. You can't do that on an airplane now, but you can do it with Axiom and Zoom. And we're going to hear from doctors from Italy and France. Unfortunately, they're a few weeks ahead of us in this, and learning from that experience could be very important. And then we'll have questions. So without any further ado, I just want to thank all the panelists for taking their time on a Saturday morning. They're all clinically focused, and we all know as clinicians, this is a trying time, trying to take care of our patients, trying to take care of our friends and our families, ourselves. It's really something like I've never seen. I don't think anyone's ever seen. The only positive is I think we'll all be better for it when we get through this as we move forward, and it will happen. It just is a question of when. So I'm going to start with Dr. Jack West. You know, Jack is from the City of Hope, and actually Jack already leads telemedicine there. So who better than Jack to give us 5 minutes about how he's using telemedicine and his colleagues? Jack.
Thanks very much, Roy. I'm happy to be talking about this. It's unfortunate about the circumstance, but I do think that there are some really valuable things that will be born out of this, and one will be a much more efficient way of treating many of our patients. I came to City of Hope just over a year ago to really pilot the remote consult service that has been working on using a telemedicine platform as an alternative to people coming from various parts of the US for a campus visit. But frankly, we had underutilized that, just like most of us had underutilized telemedicine in general, despite having the technology, having the hardware and usually the bandwidth for it. It had more just been an issue of not having a clear enough need or incentive, and COVID-19 or the risk of coronavirus exposure really catalyzed that. So we increasingly been using that as an alternative to patients coming for traveling to the campus for a visit, and having an enhanced telemedicine experience of having people see maybe 2 or 3 different specialists, to, you know, a med-onc, rad-onc, maybe a surgeon, social worker, whoever, but coordinating all of that to be done through now telemedicine is increasingly possible, though we are still having to work through the limitations of state licensure. That has been revised very rapidly in the last couple of weeks, but is still ongoing. And so different states have different issues. So that's one platform, but the other is just our routine clinic use, where this threat and concern about patient exposure among folks who we're routinely seeing in our clinics has led to us pulling back and reassessing which of our patients can be perfectly well managed through a telemedicine visit as an alternative. And for patients who are doing well on a targeted therapy, and we would just be checking in with them, maybe doing a scan, possibly labs, following up on patients starting a new treatment, but checking on how they've been feeling over the last couple of weeks. There's many, and certainly patients for more routine surveillance, maybe after they've completed their treatment. There are a lot of our patients who are well suited to a telemedicine visit. And as we are getting that experience, we're realizing that that we can continue to use this. This is very, very efficient and very convenient, not just for the docs, but especially for the patients who don't have to travel as many of them would have to for these, don't have the exposure issues. So it's extraordinarily well suited for a time of concern for social distancing and minimizing exposure. But I do think this is something that is teaching us that we can be judicious about which patients need into the clinic and which ones moving forward are going to be well suited by intermittently doing a telemedicine-based visit and saving them travel into the center and the parking and all the issues that that many of us face at our cancer centers, just with the spatial challenges. So I think this is something that not just City of Hope, but many in the U.S. and I'm sure around the world are gaining experience very quickly in, and we will be different now after this, even hopefully after this has become of a concern in the next few weeks to months.
Let's go to Rohit Kumar now for some another perspective on resource optimization.
Thank you. I'm both on my landline and on the phone here.
Go ahead.
I do echo everything that Dr. West just mentioned. So, but there's the certain things are unique to cancer patients, especially when there's small cancer hospitals that deal mostly with volume of outpatients, and also the way I would look at it is two ways. One is using the outpatient resources and then the inpatient resources. For outpatients, telemedicine has been relatively well established, and we work a lot with trying to figure out who, in this current situation, which is the patient that needs to come in to be assessed and evaluated. On that aspect, I'd say triaging the patient, especially who's calling of the respiratory problem, becomes the most challenging thing. Probably the best way to do that would be to initiate a telemedicine phone call, and then depending on the patient's symptoms, the way we've dealt with it is if somebody calls in with symptoms that seem mild, we ask them to observe for a couple of days. If a patient seems like they're sicker, especially people who are on, for example, immunotherapy or TKIs or so, we prefer that they come in, get a swab. We're now up to being able to get a test run and done within 24 hours. So those patients come up, drive through, get in a swab, and go back home. The other patients who are a little more sicker at that point of triage can then be admitted to an area which is designated as COVID positive. So we've had this unique advantage now of where we have two hospitals adjacent to each other, and we've kind of worked on making one building COVID positive and one building trying to be COVID negative. So all patients, whether they're cancer, even cancer patients that belong to Fox Chase are now being admitted towards the non-cancer hospital, and vice versa. We've helped is that patients who are non-COVID, non-cancer patients who need a higher level of care, like an ICU level of care, are being admitted towards the Fox Chase ICU. So I think that kind of channels and segregates people appropriately. And but the bottom line of this is the way this becomes effective is only if you're able to do effective and widespread testing, which is very efficient and comes back quickly. Otherwise, triaging becomes hard. On the inpatient side of things, the other part which becomes very important is trying to get a sense of your personnel and your equipment. We've kind of worked with our anesthesiologists to figure out, how to use our ventilators if needed, or the anesthesia machines as ventilators, basically. So that's a work in progress. So far we have not needed to do anything like that, but that is another resource that we're trying to optimize and use. One thing I would like to mention, kind of slightly separate from the topic, but I think is going to come up as we all face shortages for PPE, is the use of masks. So we have also started doing decontamination for our N95s. CDC has approved of a few methods that can be used to decontaminate N95s, and we're using heat as the modality to use. There's UV light can be used, hydrogen peroxide can be used, but we're starting to use dry heat to help recirculate the mask. So basically, we start with one N95 during the morning. By the evening we send it on for getting autoclaved, and the same mask comes back to the same person until we inspect that the mask is no longer fit for a user. So I think that's another aspect where we've tried to optimize some of our resources. The other part, which is probably helpful, especially on the inpatient side of things, is to try to pair resources as much as possible. So having staff work at finite amount of shifts and then get a rest period. So you can pair a couple of nurses taking care of inpatients for 3 days in a row and then give them a break. Since something similar can be done at the end of the doctors also, where you have a doc care take care of patients regularly for 4 or 5 days and then get a break for some time. And I think that's really helpful. That's a lot that we've done in terms of just restructuring internally what we can do. I think Dr. Manley is going to speak a little more about specifics in our ICU otherwise. Also, what I would say is, although there's broad guidelines about how to, who to consider for a bronchoscopy and all, and try to push back most procedures or so, there are situations where you cannot do that, and we still have to think individually about one particular patient. So I think that's where you would try to, talk with the oncologist directly one-to-one and discuss each scenario case by case. You can't ignore that 5-centimeter mass for 6 to 8 weeks or so, for example. So I think those are situations where, I think still an open discussion, pick up the phone, talk to each other is really important. So I'll stop there for now. And thank you.
Thanks, Rohit. We have almost 250 people online now. I'm going to turn it over to Haas now for the next session. Don't forget to ask questions.
Thank you, Roy. Appreciate it. Thanks. Please submit your questions using the Q&A function that you see on Zoom, and we will address the issues and the questions that you have towards the end of the program. Our next speaker is going to be Dr. Christopher May from Fox Chase Cancer Center in Philadelphia. He is a pulmonary medical care specialist, and he is going to talk to us about the specific issues that arise in the ICU setting for patients with COVID and a history of cancer.
Thank you, Haas. So I'd like to first start by talking about risk for severity of disease. So from early studies, we know that patients with cardiac, respiratory, and kidney disease do worse than other patients. Also patients of advanced age, but we see that's not standard across the board. One of the other signals we're starting to pick up from early data is morbid obesity and hyperglycemia, possibly because of the hyperinflammatory syndrome that this causes. When we think about taking a patient to the ICU, there's a few reasons for them to come. First and foremost, with these patients, they develop hypoxemia. And the question for us frequently in cancer patients is that hypoxemia due to an infectious process or something else like pneumonitis? So ruling out these patients quickly is important. And while tests were not available early on for COVID, it meant taking a detailed history. And once this was a community spread pathogen, history questions like travel to China, being in contact with someone who was COVID positive, didn't carry as much weight as symptomatic questions. Shortness of breath, chest pain and chest aches was a big one. Joint pain, muscle aches, fatigue. But in other patients, we were seeing GI symptoms like diarrhea in 5 to 10% of patients. When patients become critically ill and are intubated, the decision was made to intubate quickly so that we're not using things like non-invasive ventilation, which is aerosolizing particles for the staff members in the room. Things like nebulizers, high-flow nasal oxygen, CPAP and BiPAP all have the potential to aerosolize small particles that would require an N95. For typical patients who are in a clinic visit or on the floor or infusion room, we think a surgical mask and eye protection is adequate. Now, when a patient comes to the ICU, as I said, hypoxia is one of the main ones, but we're seeing differences in the ARDS pattern compared to traditional ARDS patients. One is these patients have severe hypoxia but preserved lung compliance. And so ventilating these patients with traditional strategies has been a challenge. They're typically not as PEEP dependent, and they have hypoxia that is sometimes refractory to prone position or paralyzing them. One other thing that we're seeing is cardiac complications such as myocarditis. Sometimes patients will pass the hump from a respiratory standpoint. They'll start to improve, be extubated from the ventilator, only to see a severe myocarditis and cardiac arrest. Other things like diffuse encephalopathy can be severe and long-lasting. And finally, acute kidney injury has also been a significant factor in treatment of these patients. Now, in putting this all together, keeping staff safe, keeping patients well supported, we're keeping pumps outside of the room so nurses can attend to them quickly. We're limiting the number of nebulizations that are given, limiting the use of CPAP and BiPAP, but it is still a challenge caring for these patients. When considering treatments, there's a few things that have been tried, but they still lack long-term, large randomized controlled trials. One of the first was remdesivir, which decreases RNA synthesis, and then some immune modulating things because we think about the cytokine storm and high immune response. Now, those have been IL-6 inhibitors like tocilizumab, IL-1 antagonists like Akindra, and then other immune modulators like steroids and Plaquenil. Now, we're not sure which of these is going to work. Early studies said steroids may not have a positive effect, but in some of these patients with cytokine storm and myocarditis, steroids may have a role. So you see this is a very quickly evolving landscape, and we're learning day to day.
Thank you, Dr. Manley. I think that was great. I'm sure we're going to have a number of questions for you, and we're going to come back to some of this, some of the issues that you raised later on. It gives me great pleasure to introduce our next panel speaker and one of the organizers, Dr. Hope Rugo from UCSF, who is going to talk to us about early breast cancer treatment and also moderate a little bit of a discussion with some of our other colleagues regarding management of patients with breast cancer. Dr. Rugo?
Thanks so much, and thanks everybody for being on this morning, and also for the organizers for doing this conference, because it's so nice to have a community to talk to about what we're doing, and to also use the chat function, the question and answer to the attendees, because I think that that's actually really expanded a lot of the interesting conversations we've had. You know, breast cancer is the most common cancer in women worldwide, and so the treatment of breast cancer in a pandemic setting is a really critical question, I think. And although our therapy in general is less immunosuppressive than, say, bone marrow transplant, we treat most patients with something. So how we decide to treat these patients is complex, and the data that we have from China includes a very small number of patients with breast cancer. So we really just don't have that data right now. We've talked a lot within our various groups, ASCO, NCCN, our international colleagues, and of course at our own institutions, to try and figure out how we can really manage patients in the best way. we're really dealing with two major situations in terms of disease setting and three major questions. So one is treatment of patients who have potentially curable disease. We cure most women with early stage breast cancer. How we decide on timing and treatment is really critical in this situation, with the goal to try and reduce the number of visits and risk to our patients, and also reduce the use of ventilators in the operating rooms and use of PPE in order to have that resource available for patients who are more critically ill. So what we've really done is to try and do several things. So for patients with early stage disease, we've promoted the use of neoadjuvant therapy as much as possible in order to delay the need for surgery. So in patients who have hormone receptor positive breast cancer, we have a number of women, of course, who are postmenopausal, older, with slower growing cancers. These patients could be treated with endocrine therapy for many months, up to 6 months or longer, as long as their tumors are controlled, before they go to surgery without reducing their outcome. In patients who have cancers that need chemotherapy, we have started with chemotherapy first. Of course, that means that patients need to come into the hospital, but we're trying to really expand the use of growth factors, keeping in mind that there may be a risk for growth factors you have in patients who have interstitial lung disease, but reducing the visits to the hospital, reducing the risk of febrile neutropenia is really important. And to that end, last week, the NCCN Hematopoietic Growth Factor Panel listed a guideline for patients during the pandemic in terms, and providers, in how to use growth factors. That's very helpful. So using neoadjuvant therapy, then the question comes up in patients who have an excellent response, when do you go to surgery, even patients who do not? We've actually tried to keep our surgery schedules in patients who have curable disease, for example, triple negative, HER2 positive disease, and high risk hormone receptor positive disease, because those cancers are unstable and surgery timing probably does make a difference in these patients. And I'll talk about clinical trials just in a moment when I get to metastatic disease, because I think that that affects our patients primarily in the metastatic setting. For patients with metastatic disease, where we're treating in the curative setting, in the palliative setting, and rather than curative, and I will keep in mind, I will just add in the comment that for patients who have early stage, high risk hormone receptor positive disease, we treat with endocrine therapy, but we actually are continuing patients on clinical trials with CDK4/6 inhibitors. We know it causes neutropenia. We're trying to limit visits and having people do telemedicine visits as much as possible, as long as they don't need to come to the center for injections. And patients on ovarian suppression, we're trying to expand the ovarian suppression to be every 3 months when it works versus monthly. It doesn't work well every 3 months in very, very young women, but otherwise it does. For metastatic disease, it's tough because we're treating in the palliative setting, but not treating results in a worse symptoms and worse disease. So we've continued our chemotherapy in these patients, but we've tried to increase the less frequent dosing treatments, treat every other week when it works well for patients, and the use of growth factors. We've reduced the frequency of laboratory studies in patients who are on oral therapies, and tried to use telemedicine visits when we are treating patients with oral treatment like capecitabine, endocrine therapy, and targeted agents with endocrine therapy. There has been discussion about patients in the metastatic setting getting their antibody infusions every 4 weeks rather than every 3 weeks. We have used this in patients who are way far out, so many, many years out, very stable on their antibody therapy. But I have to say, I'm still anxious about that in patients who could potentially have very long survival on every 3-week antibody therapy. And then lastly, I think the biggest issue for all of us, other than treating our patients, is clinical research, because we feel that offering clinical research options to our patients is so incredibly important. And right now, many of the clinical research studies are on hold. Anytime we have to do pharmacokinetics or provide clinical research samples are difficult. I wanted to, and we expect this to open up again, we hope in the next few months, and we've continued in clinical trials where we don't have to do the research biopsies or provide pharmacokinetics. I wanted to just have Dr. Strigliano comment about what they're doing in breast cancer in Italy briefly, and I know he'll also briefly mention what's going on in Italy afterwards.
So, we did exactly the same thing you did. So we defined some priorities finally, and we are going also to publish in the context of the European Society of Medical Oncology. And I mean, for us, the best of care should be delivered when you have a curative intent, or when you can impact on outcomes. So we never stopped neoadjuvant treatment for triple negative HER2 positive breast cancer. And in the metastatic setting, if you have a first line HER2 positive, we try to deliver the best of care. The only surgery we delayed were related to the CIS, of course, or for patients with luminal A cancer for whom we started endocrine therapy in order to delay surgery. But in the majority of the cases, we tried, because I will explain to you later, we had a specific organization in the north of Italy. We tried to guarantee the best of care in order to avoid to impact on outcome of the patients.
I think it's time to move on to one of our melanoma experts. Dr. Harriet Kluger is here to talk to us again about immunotherapy and the decision-making process when it comes to the use of immunotherapy because of potential issues that might arise as a result of the use of immunotherapy in patients who might also be diagnosed with coronavirus infection. So let's have the discussion. Dr. Kluger, please.
Thank you. Good morning, everybody. And I'd like to thank also the organizers for putting together such a well-organized thing. If somebody could put up a hand when you don't hear me, I'm a little bit worried about the bandwidth of my connection. But I'm going to start off with mentioning that the melanoma community got together about 2 weeks ago and made some specific recommendations for the pandemic for treatment of melanoma patients that were fairly broadly vetted. And I'm going to go through some of the measures that we're taking disease setting by disease setting. So starting off with patients who are on adjuvant therapy, the general consensus is that immunotherapy probably does decrease the likelihood of metastatic disease by about a third, certainly at the 3 or 4 year mark. But what we don't know is whether it prolongs survival ultimately in the long run, as opposed to rescuing someone when they develop metastatic disease, because we do know that in that setting, we can still salvage about half of our patients with probable cures. So it's very different than breast cancer when we make these decisions. I think in the adjuvant setting, people are a little more gun shy with putting patients. There's a recommendation now for adjuvant pembro to go out to 400 milligrams every 6 weeks, as opposed to 200 every 3 weeks. There are no data really to support that from clinical trials, but that's what a lot of places are doing. Just to throw in there that we also give BRAF/MEK inhibitors for patients who have BRAF mutations in their tumors. And the big problem is not so much complications of meningitis, but these patients get fevers. And they're calling in with their drug-related fevers all the time. So we're very fortunate as of yesterday to have opened a rapid assessment clinic. So it's kind of like a fever clinic where patients can go in, get swabbed, get assessed very quickly and go home, and then 3 or 4 hours later they have a result as to their viral status. And obviously if they're negative, they're just told to hold BRAF inhibitors and sit tight. So in terms of metastatic disease patients, that's where we have our biggest challenge. We know that if we push, especially patients with aggressive disease, if we push them in the frontline setting with dual therapy with ipilimumab and nivolumab, the outcomes probably are better in the long run. We have seen a couple of patients who are COVID positive so far and who do have chest symptoms. I think the lung cancer docs on a regular basis see much more pneumonitis than what we see. But obviously we see it from time to time, and it's very difficult to differentiate between pneumonitis from a drug, and we certainly don't know whether we're worsening the disease in patients who are exposed to COVID virus. I'll also throw out there that there's a hypothesis that patients on immune checkpoint inhibitors might actually be able to handle virus better because they've got a lot of T cell activity. So certainly, as long as it doesn't go into the lungs and have the multiple virions over there, you may be actually doing better than patients who are not on immunotherapy. So we're trying to study that, but as of now, we don't know, and we're just really trying to do what's best for our patients on a day-to-day basis. We're trying to postpone our follow-up patients as much as we can. Patients who are having scans, we do televisits just like everybody else. I think that inpatients propose a specific problem So patients who come in with fevers and symptoms who are on immunotherapy who may test negative, as we all know, could still actually have the virus. And we're suggesting repeat testing on those patients at least 24 hours apart. Our clinical trials operations, like many other folks' operations, have come to a halt. We have huge challenges with patients who've started on cell therapy protocols. Again, do have a chance of cure from these cellular therapies, and we're trying to push them forward as much as we can, similar to what's done for bone marrow transplant patients. So I will stop there.
Thank you so much for that introduction. Again, we are getting really, really good questions. Please keep the questions coming. We will cover as many of them as we can at the end of the program, and we will probably address many of them under a specific section because there are a lot of similarities between the questions. Next, we're going to go back to lung and talk a little bit about the patients with lung cancer and how to optimize treatments across different stages. And we are, again, fortunate to have Dr. Mary Davies with us from Yale Cancer Center. She holds a Doctor of Nursing degree and has been dealing with various aspects of lung cancer care at Yale for over 20 years. So we're very happy to see and hear her perspective about management of patients with lung cancer. Dr. Davies?
Great, thank you very much, and thank you to the organizers as well. It's unfortunate that we have to meet in this particular way. I'm just going to follow on what Harriet said in terms of the group coming together and making some decisions about how we collectively are going to manage our patients with lung cancer. And all of the pulmonary and lung doctors at Yale, as well as across the region, have kind of come together to make some different decisions. So I'll start out first with our patients that are on oral targeted therapy that have single point mutations. For those patients that have been stable on their oral medications, we are continuing to do telemedicine for management of those. We are not bringing patients into our main facility for monitoring of blood work. We're having that done at external satellite sites. In many cases, when patients do have progression on these targeted therapies, we oftentimes will have rebiopsies to look at mechanisms of resistance. And so now, instead of doing those biopsies, we are relying more on liquid biopsies to minimize the use of our bronchoscopy suite and other interventional radiology suites. In terms of the scans that we typically do, we've been in a routine where we oftentimes are doing scans on an every 2-month basis for patients on the targeted therapy, and we've moved those out for patients that are stable to 3 to 4 months of monitoring. In terms of patients that are on systemic therapy, other than the oral targeted therapies, we're also changing the routine of how often we're scanning patients and making an attempt to do those scans at external sites so that we're not bringing them into the main hub of the hospital to have those scans done. For patients that have locally advanced non-small cell lung cancer, the typical treatment is chemotherapy, radiation concurrently, and that is followed by durvalumab therapy for 1 year. Typically, the durvalumab has been scheduled on an every 2-week basis, and we have now moved that out to flat dosing to every 4 weeks. And if insurance is not covering the increased dose, we're still going to continue with the standard dosing and push that out at least every 3 to 4 weeks. For patients that have the recommendation of pembrolizumab for monotherapy, which is approved for patients in the first-line setting that do have PD-L1 expression, we are now switching to an every 6-week dosing of 400 milligrams as well, and we are expecting that is pending FDA approval at this time. It's already been approved in Europe at that dosing. For first-line non-small cell lung cancer, for patients who have at least 1% PD-L1 expression and no contraindication to immunotherapy, we are sticking with the pembrolizumab dosing every 6 weeks in an effort to avoid the cytotoxic chemotherapy for those patients. For patients that are having progression after first-line chemo-IO therapy in the advanced non-small cell lung cancer, so small cell lung cancer, we're considering that perhaps we're not going to go to second-line chemotherapy in those patients, but keep those patients in an observation only mode. For those patients that have been on maintenance therapy for non-small cell lung cancer or mesothelioma, we're oftentimes omitting maintenance chemotherapy and changing maintenance to just be with the pembrolizumab every 6 weeks. We've made a collective decision to really consider the length of time that we're doing maintenance therapy, and oftentimes making a cutoff if people have been on maintenance therapy for an extended period of time with stable disease, that we are discontinuing that immunotherapy. Those patients with non-small cell lung cancer that do have metastatic disease, if it's oligometastatic disease, there's consideration for discontinuing the systemic therapy if all of the sites of the oligometastatic disease have been well controlled. Some of the other things that I just wanted to bring up are some of the challenges the patients with lung cancer are having. Oftentimes they do have compromised pulmonary status, have long existing COPD. So assessing these patients in terms of their risk for COVID can be very, very challenging. One of the other things that I'm hearing a lot from patients is that they're having difficulty obtaining their standard nebulizer treatments and inhaler therapy because there's been such a rush at the local pharmacies for patients wanting to receive those therapies that don't have those underlying COPD issues because of the fear of COVID. We also are hearing a lot of issues from lung cancer patients that are on chat rooms, very concerned that because they have an underlying lung cancer, even if they have very stable disease, that perhaps they're going to be, quote unquote, discriminated against, and that they will not qualify for going on a ventilator if they have advanced COVID-related issues. So those are some of the things that we're having to deal with a lot of our phone calls, and really just helping to manage patient expectations now, because they feel that they're going to be automatically grouped on an algorithm to not receive more advanced care. So I think up there, and go to the next person.
Great, thank you so much. Really appreciate your insight. That was great. We do have some questions for you. Again, I'm going to come back to it. I think one of the more challenging areas in terms of cancer care is care of a patient with a head and neck malignancy. And again, I am very pleased to have one of the top experts in the world, Dr. Barbara Burtness, joining us from Yale Cancer Center to discuss some of the specifics related to this particular group of patients. Dr. Burtness?
Thank you, Haas. I did break the rules on slides because I wanted to share this website. globalsurge.org has now started a registry called Cancer COVID Surge. And I think particularly in head and neck cancer, this is going to be extremely important for people to participate in and track the outcomes of the different mitigation strategies that people are taking. I think people on the phone may be aware that COVID viral load is the highest in the nose and the mouth. I mean, that the loss of smell, the loss of taste, the acquisition as a respiratory airborne virus. So the risk to healthcare workers from aerosolization from any procedures in the nose, the oral cavity, the pharynx, the hypopharynx is extremely high. And there are reports of extremely high transmission of COVID to healthcare workers, specifically from ENT procedures. There's one case of a benign sinus procedure where 16 out of 16 people who were in the operating room for that procedure converted. So there is great sensitivity on the part of our surgical colleagues to using surgery appropriately and doing it when it is life-saving and when there are other strategies that are also quite likely to lead to disease control that would be lower risk, to consider those. It's also the case that given the personal protective equipment requirements of having people in the operating room for a head and neck procedure, these procedures are going to draw a lot of resources. Surgical reconstructive approaches after head and neck surgery are phenomenal nowadays, but these can be very long operations with very high blood transfusion demands and very long post-operative hospitalizations and even long post-operative unit stays. So in our current resource environment, these operations are problematic. So the nature of this registry is that if you assume that there's a pool of patients awaiting head and neck surgery, some have elective operations, some have emergency surgery because their airway is going or they're bleeding, but many may have delayed surgery, atypical neoadjuvant treatment, or indeed non-operative management, and they want to collect the data. There's a similar database that's being set up to look at outcomes from alternate radiation and chemoradiation strategies that there was an international call about yesterday. So I do think that people are tracking these data. I know that the group at Milan already has a 600 patient database that we're going to be able to refer to. So just in terms of what happens when our patients come in, we continue to rely on our multidisciplinary tumor board to figure out what are the operative or non-operative strategies that a patient needs. If we're doing something non-operative that involves induction therapy, we're staying away from the tried and true TPF regimen because that has a very high rate of neutropenic fever, even with growth factor and prophylactic antibiotic support. And we want to keep those patients out of the hospital and we keep them from being profoundly neutropenic. So at our institution, we've moved to the old ECOG regimen of weekly carboplatin, paclitaxel, and cetuximab, but there are other less intense induction regimens out there that others are using. When we do combined chemoradiation, although there's overwhelming bulk of the data are behind the use of high-dose cisplatin, that is a regimen that results in more hospitalization, more renal dysfunction, and we are concerned that hospital resource utilization, the risk of nosocomial infection, and in fact, as we were hearing from Dr. Manley earlier, the possibility that if you develop COVID while you're experiencing renal failure, that your outcome would be worse. For all of these reasons, we've moved away from high-dose cisplatin towards either weekly cisplatin or a carboplatin-based approach. As you heard from a lot of the other diseases, we are still continuing to use immune checkpoint inhibitors. There was an early concern that this might be something that would lead to worse outcomes for patients because they might be at higher risk for the hyperinflammatory state, but we have not really been able to get data from either European colleagues, and I'm curious to hear the later segment of this webinar, what people feel, but we've been continuing to use the IO agents and moving pembrolizumab to the 6-week schedule that's been approved in Europe. We do a lot of hydration for our patients on cisplatin. We're trying to set that up for home to minimize their time in the center. When we have patients who are in complete response on immunotherapy, the standard of care has been 2 years of treatment. There's never really been any discussion about whether we ought to study 12 versus 24 months, but we've been much more likely to discontinue IO in patients who are already well into a complete response. In the postoperative setting, our patients have about an 8% benefit from the addition of chemotherapy, but it markedly increases complications and risk of hospitalization. So we are reserving the chemo for the most egregious cases, the most gross extranodal extension, and the patients with positive margins. I want to say a word about the fact that head and neck cancer patients, that we have these two groups, the HPV-associated cancers where prognosis is usually very good, and the HPV-negative population where socioeconomic status is lower, education is lower, and this is a group of patients who've often been relying on others for rides. Our volunteer ride service is fraying a little bit, and they actually have been kind of hard to convince about the importance of hand washing and social isolation and so forth. I think they just had been a little bit less aware of what's going on. So we've had to do a lot of extra education for them in that setting. So thanks.
Thank you, Barbara. And please put your questions in the Q&A. We're now going to go to Italy. And I think one of the strengths of the program today is we're going to hear from Europe and both the clinical and research experience. And I'm going to actually ask Paolo to go first because of some timing restrictions. So we're very fortunate to have Paolo Acierto, of course, is expert in immunotherapy and treatment, but certainly is dealing with a great clinical burden right now, I'm sure, and his time is a little bit limited. So Paolo, can you tell us a little bit about your experience in Italy, please?
Thank you, Roy, and thank you to all of you organized for this kind of invitation. So the rule, of course, the most important rule at the moment that we consider is to keep everybody safe and to keep the priority of the patients who need priority, of course. So for these reasons, the metastatic patients on treatment are the patients with high priority. And all that we did is, as I already told, to keep everybody safe and to avoid the possibility to spread the infection among our patients. So regarding the follow-up for this reason, this moment, we are optimizing the follow-up because we have in follow-up something like 5,000 patients with melanoma at all stages. So we are doing electronic follow-up. So by web, by telephone. So we ask patients to send us the exams and then we evaluate just in case of if necessary to have also the clinical examination, we ask the patients to come in our institute. And also about the surgery, we are prioritizing the patients with deep lesions and the high-risk lesions for the staging with sentinel node biopsy. About the adjuvant, what we are doing at the moment, if possible, we are trying to postpone because we have 3 months to start adjuvant treatment, and when possible, we are postponing. In the BRAF mutated, we are preferring at this moment tablets because we can manage tablets at home. But we have at the moment some patients on treatment with the anti-PD-1 as adjuvant. They have to say that we have 2 COVID-19 patients positive. They got the coronavirus infection after the 5th cycles. At the moment, we stop it just to be cautious, but the patients are good, just infection and a little bit of fever, but nothing else, nothing more. And so we are evaluating. About the metastatic patients, all that we are doing is similar to what we did previously, the COVID-19 infection. What we are trying to do is to change the schedule in the 4-week schedule. So we are trying to give the longer schedule still in order to avoid to have a lot of patients in the same area to avoid the infection spread. Clinical trial at the moment, several clinical trials, more phase 1, are on hold because there are some about the PK and other tools that in general we do during the phase 1. At the moment may be a problem for the quality of this data. For this reason are on hold some of these clinical trials. And then patients were already enrolled in clinical trial at the moment, according to the monitor, are managed also mainly for the patients who are at a lot of distance from our sites, even by email or by telephone call. 2 problems, practical problems that we have with patients on treatment with the BRAF intramediate, that the fever is the most important side effect. And in case of fever that don't disappear after the stop of treatment, of course, we require the nasal swab in order to be sure that is not related to the COVID-19 disease. And also, in case of patients with pneumonitis, sign of pneumonitis, and these are patients on treatment with checkpoint inhibitor and mainly anti-PD-1, if no fever, of course, we believe that we can treat the patients with steroids if required. If there is fever concomitant to a CT scan, a picture of a pneumonitis, we still do the nasal swab in order to avoid, again, that this is a pneumonitis related to the infection and not to the checkpoint inhibitors. So this is what we are doing in summary. And as you know, Roy, we are also doing a clinical trial, national trial about the use of tocilizumab in case of COVID-19 pneumonia. I don't know if I have time to say something. If not, of course, I can do later on another occasion.
Why don't we do that later? Just one word. How are you doing clinically there? How are the resources?
So about the resources at the moment, we have no problem, I have to say, because we have fortunately no infection among the personnel, among the doctors, so we are not suffering, and all is good at this moment. What we did is also to start a smart work for the study coordinator and the people that we don't need to stay in the hospital. They are working at home.
Okay, great. Well, we'll talk about TOSI a little bit when we have the roundtable. Let's go now. Thank you so much. Let's go now also in Italy to Dr. Giuseppe Progiano, who's at the European Institute. And Giuseppe, a few thoughts from you about your experience in Italy, please.
You know, maybe you should know that the epicentrum of the infection is in the northern of Italy and not in the south. So all the cases that we have in Italy, almost 100,000 are concentrated in Regione Lombardia, where I live. So the COVID infection is specifically a problem of the north of Italy. So in the other places, they are controlling very well the spread of the infection. So we had several problems at the beginning because hospitals were overwhelmed by hundreds of patients arriving. You have to consider that we built a new hospital in Milano, the Milano Fiera Center, that is an exhibition center for 300,000 people, has been opened as a new hospital with 500 places of intensive care unit. So in terms of organization, what we did is to reorganize the national health system, defined spokes and hubs for any type of disease, of course. So we have cardiovascular hubs and we have cancer hubs. So in terms of cancer treatment, so in our region, we have 2 cancer hubs that are my hospital, the European Institute of Oncology, and the National Cancer Institute. What does it mean? It means that if you have a patient with lung cancer or melanoma or breast cancer in a spoke hospital where you have a lot of COVID patients, so you cannot take care of cancer patients, this patient will be referred to the hub hospital. So that's why with this reorganization, we are really doing our best to take care of our patients and to guarantee the best of care to our patients. This is quite an important point to be stressed because in the National Cancer Institute and in the European Institute of Oncology, we have very limited numbers of COVID patients. I mean, actually in my hospital, we have 8 patients. And in the National Cancer Institute, they are close to 10. So we have a small unit in the hospital with trained nurse and trained doctors that will take care of those patients. And the pathways for the other patients is COVID-free. This is quite important because we can guarantee, of course, the best of care for all the patients. We defined some priorities. So if you have curative intent, you do your best to guarantee on-time surgery, neoadjuvant treatment, and adjuvant treatment. So we defined priorities that are based on age, comorbidity of the patient, clinical benefit you can achieve with the type of treatment you select, and long-term outcome. So we prioritize according to this type of scores. And of course, considering that in Italy we had 14,000 deaths, and in my region we had 10,000. So the COVID experience is much more concentrated in our region. And so considering that the case fatality rate was related to elderly population with comorbidities, we decided for those patients to de-intensify treatment, of course, avoiding access to hospital, doing telemedicine for follow-up visit, and of course, giving treatment with less risk of leukopenia. So this is the situation. Actually, we are going to flatten the curve, at least in my region. In the last 2 days, we had less than 500 deaths per day, considering that 1 week ago, there were 1,000 deaths per day in our region. We are discussing of our region that is a part of Italy. Now we are doing better, and I believe for the future we need an epidemic control plan to be planned every year, because now we understood what is an epidemic.
Thank you. That sounds a lot like New York, which is not far, where a number of us
exactly like New York, correct.
So I'd like all the panelists to be able to respond to the questions that are coming. Here you are, Fabrice. I'm sorry, the voice connection wasn't really working. So we have received a number of questions regarding management of patients with breast cancer. I know that some of the answers were, some of the questions were answered by our experts, but I think so that the whole community who's online can benefit from this, perhaps our breast cancer experts can give a quick perspective in terms of early stage disease, delaying some of the treatments when appropriate. But please keep in mind that we don't have a lot of time, so if you can condense the discussion, I think that would be good. Dr. Rugo, do you mind taking that section and sort of, again, briefly talk about the management early stage versus metastatic, and what treatments could potentially be delayed without harming patients, and which ones you absolutely feel we have to go ahead with?
Yes, I think it's a really important question, and it's come a lot. First is a patient who has curable disease in the early stage setting, we want to optimize their options for cure. So we are giving neoadjuvant chemotherapy. We always gave a lot. The general communities emphasize the use of neoadjuvant chemotherapy, and in patients with very indolent chemotherapy unresponsive disease, use of therapy. So then we go on to surgery, but we don't want to delay the surgery in patients positive or triple negative or very proliferative hormone receptor positive disease. So we're really prioritizing surgery for those patients, and very risk disease radiation therapy has continued as well. We have to make an individual decision for each and optimize their chance of curative therapy. We are using adjuvant therapy, and we have continued our patients who are on adjuvant CDK4/6 inhibitor trials without all studies. In the metastatic setting, we have continued chemotherapy in patients who are on chemotherapy because we know that it improves their survival and symptom control. And if we don't control their symptoms, they're going to end in the hospital anyway. And certainly, patients who are from treatment, we want to continue that therapy. We had an interesting discussion in the A section about use of CDK4/6 inhibitors. We've continued the use of CDK4/6 inhibitors because of the mark. I think in a patient a lot of toxicity, you could safely stop the agent for a month or two and restart it. We haven't made decisions about not giving that therapy based on COVID. We are using oral therapy when can rather than IV therapy, and we are taking frequently in patients on CDK4/6 inhibitors or on capecitabine, and trying to really promote video visits. Patients with IV therapy need to come in, so we do them in week labs in our center. I think one of the questions that come up for us is a patient on curative therapy who develops COVID-19, and thankfully in our clinic we've had one patient remarkably with COVID-19 who worked at the airport, and just about when to restart therapy. She's on trastuzumab and pertuzumab, and again this patient is controlled on those antibodies in the de novo vaccine. Situation we have done, and again, learning with the community as we go along, is she had and to be about a week out from last symptoms, and to ensure that her symptoms have resolved. And if those three criteria, the patient can come back to the infusion center in order to receive antibody therapy. I'd be interested in other people are using actually for criteria for patients coming in. We also staff our respiratory screening clinic, and have done my clinic today. I tested people and one is positive. Use PPE, but it's an interesting situation what you do with these patients who end up being positive and are in need for therapy because we just can't bring them to the infusion center.
Thanks, Hope. But I'm going to take a little different tack, and we've had a number of questions. I see Janet Freeman Daly on the line, patient advocate, about patients going through all this, and a couple of issues. One, patients with metastatic disease, should they end up needing intubation either because of their disease or possibly having COVID infection, how to support them and to support them in the eyes of the intensivists. So she asks, have any of you considered writing letters about your patients, and putting them in the chart, or how are we noting this and how are we interacting in our different centers? So that might be interesting. I don't know, Fabrice, if you're back on. I heard you called in, and if you heard that, or let me know. Perhaps you want to take that first, because I'm sure in France you're having many patients that are needing advanced care. If not, would any of the other panelists like to take it? Barbara?
I mean, it's
This is
interesting
Barbara
for
Witness. I'll just tell you what we've
great if
done.
you comment on that.
Oh, who raise your hand if you want to speak.
So for the head population, we've been doing it as an addendum on the most recent note for everybody, and encouraging the patients to print it out from my chart if they can, or giving it to them at the visit. But particularly HPV positive cancer has an extremely high cure rate. We're worried that people outside the oncology field might not know that. And people with HPV negative cancer who are more than 2 or 3 years out from diagnosis are cured. And we are quite concerned that people will see in the chart head and neck cancer, think it's a bad prognosis situation. So we have been trying to give them something on paper to carry with them.
Christopher, have you had to deal with this as an intensivist?
So I think it's it's a little different in our area because we haven't been faced with rationing yet. I think that there's also a big difference between being forced to ration based on availability of ventilators and being asked to withdraw care from a patient who has a potentially poor prognosis, and the ventilator could keep them alive for 6 to 8 weeks, but they may not live 6 months. And so fortunately, we haven't been faced with those issues yet, but I think that the potential exists for patients to be physiologically stable on a ventilator. And then the question is, if they're facing trach and, vent weaning and, of all patients who go to vent facilities, 50% might not ever be decannulated. Those questions, I think it's very important to have those discussions early so that there's a reasonable expectation of care. This disease, while the mortality is higher than the flu, the general mortality is still not that high. And so we're going to be left with a significant number of patients with a long convalescence from ARDS, from myocarditis, from encephalopathy and post-traumatic stress disorder from the ICU. All of those things need to be taken into account for the 6 months or 12 months post-hospitalization.
Thanks. Anyone else want to comment on this before I turn it back over to Haas for the next question? Fabrice? Bonsoir.
Yes. I don't know if you can hear me now.
Oh, très bien.
Merci. Yes, I think it's we try to individualize as the best as we can the contact with the patients. Trying to ask our resident to participate in daily calls to the patients in order to see how they are, how they feel with treatment that are postponed. Then we try to really individualize the organization and discussion with the patients every day.
Fabrice, we're going to ask you a few more questions since now we have you. So we didn't hear too much of your talk because of the technical difficulties. I think everyone in the world is using Zoom, from 2-year-olds to 100-year-old. But can you just say a few words about clinical trials and how the clinical research? I know you have a very robust research structure at Institut Gustave Roussy. What's this doing to your clinical trials? What effect will this have on the data from clinical trials, on researching lung cancer and all cancers in the future?
Yes, in fact, we decided to try to keep as many trials open as possible. with the idea that in many situations, those clinical trials were set up in order to represent one of the best possibilities for the patients. Then we tried to keep it open, but we decided to test all of the patients included in clinical trials to test them. If they are positive, they cannot receive the treatment planned in the clinical trial and they cannot be included in the clinical trial. Then they are put in quarantine and then they come back 14 days after in order to get the treatment. For the peoples, all of the majority of the resources for clinical trials are working from home, but it works very well, I would say. One of the difficulty was to try to postpone the visit for those patients with oral targeted treatment. We asked the sponsor of the trial one by one if they allow us to do teleconsultation and then to send the treatment directly at home from our pharmacy. And in some cases, it was one of the solutions we adopted for this patient. Then we try to keep the trials open in as many situations as we could.
Fabrice, that was great. Can you give us a little perspective as to what is actually going on in your hospital right now? Do you have any data on how many patients with COVID, how many without COVID, anything in terms of a perspective for those of us in the US?
Yeah, absolutely. Then I would say for the first 2 weeks of the COVID crisis, the government decided to separate the anti-cancer center from the other hospital. And we were asked to do only the care of cancer patients. Then we decided 3.5 weeks ago to isolate our patient, and all of the people who are coming to the hospital, they are tested for fever, they are tested for sign of COVID. If they show any sign, they are tested biologically, and then they cannot enter into the hospital if they are COVID positive. We are also protecting with PPE all of the healthcare workers of the hospitals, and nobody can enter in the hospital without a mask. Then with that, we currently, for the patients we are testing with this system, we have only 7% of our patients who are positive. But just at the end of last week, the government asked us, because we are one of the only anti-cancer center in France to have an intensive care unit, the government asked us to transform and to increase the number of patients we can receive in the intensive care units. And then we opened our ICU to COVID non-cancer patients. Then right now, we have 3 units with approximately 40 COVID patients, I would say, in the general ward, and we have approximately 20 COVID patients in our ICU, and the half of those patients are non-cancer patients. Hopefully, the situation seems to improve in France. It seems that we are reaching the plateau this weekend. The number of entry in intensive care unit globally in the country seems to be stable or decreasing a little bit. Then we hope that we will be able to go out of this crisis, I will say, in the forthcoming week. And what I was saying previously is I think as oncologists, we will probably have to face a second wave, which will not be the COVID wave, but the cancer wave, because all of these patients we are postponing will come to us to say, okay, I understood that we had to postpone my treatment, but now I want to be treated, to receive my treatment, to be operated on and everything. Then I think we have to protect our teams in order to be able to very rapidly treat all of these patients, and probably our activity will also be very, very high in the forthcoming months, even after the COVID crisis.
That was great.
I think that's a fantastic. Yeah.
Yeah, that was great.
Go ahead,
and we have similar experience here in New Haven. We have about 270 patients with COVID in the hospital, and we're trying to keep our cancer patients on a separate ward, but it's hard, and the ICUs are very full. Jack West, you talked a lot about telemedicine. Someone asked the question about licensing and the ability to bill and cross state lines. I know some governors have made some certain, and CMS has made some certain accommodations, but what's the current status?
Well, it is changing very ongoing. CMS has relaxed rules and basically says that under the current circumstances, you can use judgment, and you can use Skype or Facebook without fear of any penalties for HIPAA violation, that's really not a primary concern anymore. But really it's still a patchwork state by state that is being addressed in real time. There's actually an organization and a website. There's many websites that have some kind of information, but the Center for Connected Health Policy, which is at cchpca.org, has just a repository of the current status of things, and there's an actual individual page that's like the current status for what rules are being relaxed state by state, that I just made into a bit.ly. So it's a bit-.ly/telehealth by state, all lowercase, and you can see how that's changing over time. And you know, so overall, the rules are being liberalized, but there's still challenges with going from state to state. I can drive 3 hours to Las Vegas, and my license, my driver's license, has a reciprocal utility without a challenge. But a patient in Las Vegas can't see me for a telehealth visit if I don't have a specific Nevada license, which is frankly one of the most onerous ones that you could get. It takes months and months and is extremely challenging. And you know, that has been the way states have done it, because there hasn't been a need, and they can line their coffers having very expensive state medical licensing, and it's kind of protectionist for the local doctor community. But now, in a crisis, when there's acute needs, these artificial and truly unnecessary barriers from state to state become meaningful obstacles that states are struggling to lower those barriers in real time, that have really just protected the status quo for institutions that have been the beneficiaries up to now.
Okay, Jack, thank you so much. That's really important. Now, we're getting close to the end of the session, unfortunately, and we have a lot of really good questions, but there are two main things that I'd like to bring up. I'm going to ask Fabrice, if possible, to talk a little bit about the prophylactic trials that are ongoing right now. And then when we come back from that answer, I actually like to ask Dr. Herbst to discuss the use of checkpoint inhibitors in cancer in general, and obviously in lung cancer more particular, in terms of the use of single agent checkpoint inhibitors versus combo, because we've had multiple questions about this both last week and this week, so I think we need to address that. But before we go to that, Fabrice, would you like to bring us up to date about the prophylactic trials and some of the more COVID-specific studies that you guys are involved with?
Yeah, then first we decided to try to collect serum for all of our patients in order to better understand what is the prevalence of the COVID infection in our cancer patients, also to better understand how the disease is evolving in these patients, if they are really at higher risk of complication, especially pulmonary complication or not, and what is the impact of the treatment. Then we are collecting those patients. For those who are minimally symptomatic, we are treating those patients with hydroxychloroquine and azithromycin. And for those patients with pulmonary symptoms, we are participating in a national trial, which is based on IL-6 inhibitors with the three different cohorts, and it's a randomized trial. And we are also looking to participate in a trial with potential plasma exchanges, which has been described as a potential solution for those patients. Then it's mainly what we do at the moment, and we will of course adapt our strategies after the effect, depending on the results we can get from all around the world, and especially from you guys.
That's great, Fabrice. Thank you. So the international cooperation and collaborations will hopefully continue throughout. So let's go to the question that I asked. Roy, would you mind giving us your perspective about the use of checkpoint inhibitors in patients with cancer, given the current conditions, patients with COVID or without COVID?
Well, that's a very complicated question because the question one is, what's the role of chemotherapy here? So in lung cancer, we give checkpoint inhibitors with chemotherapy. So someone's asked that question, is neutropenia a risk factor for patients? And I would think probably yes. I'd love to hear more from the Italian and French groups, but you would think that the innate immune system is involved. You can imagine that the checkpoint inhibitors, we've been trying, Marianne and I, actually we tried yesterday on one of our patients to give Pembro alone as opposed to a combo to try to avoid neutropenia in someone who had a PD-L1 high status. You can imagine that should they get COVID, that for the T-cell response, perhaps the checkpoint inhibitor can help early on. The problem is, and again, I'm turned to Christopher and others who have taken care of these patients in the unit. We haven't talked about the inflammation and then tocilizumab, Fabrice and others. We worry about checkpoint inhibitors perhaps later on in the course of this disease. Of course, we would stop these if someone got very sick, but of course the effects are more long-lasting. What effect does it have on the whole inflammatory syndrome that I think is what is keeping these patients in the unit and causing the ARDS? So as from a clinical point of view, we're trying to give IO alone. We're trying to treat as many patients. I think Fabrice said it. I worry about all the patients who are not getting treated. The clinics are very light. Where are they? They're not getting diagnosed. Surgery is not being done. X-rays are being slowed down, but they're out there and you have to try to treat them. But I'll turn that now over to Christopher, Fabrice, Giuseppe, others that have been working with these patients, anyone on the phone to talk about what they think IO and Paolo, if you're still here, how that might, just raise your hand and how that might affect the patients who are having to get COVID if they have cancer. Who wants to start that? Just put a hand up and. I'll call on someone then.
Roy,
Yeah.
This is Hope. Can I add to that question?
Yeah.
Roy, can you hear me? This is Hope.
you.
I just wanted to add to that question. Do you feel that chemotherapy with an IO is higher risk than IO alone?
That's my sense, but I'd love to know what they think in France and in Italy, where they're a month ahead of us. Fabrice, what do you think?
I don't know. We still have our Italian colleagues on the call, but we had some, I would say, information or some feeling from our Italian colleagues at the beginning of the crisis, and they said that they had some patients on IO who seemed to have more pulmonary complication, which is potentially understandable if we look at the mechanism of the potential mechanism of what we understand for the moment of the mechanism of the pulmonary pulmonary injury by the COVID and this inflammatory storm, which may be increased by the fact that those patients are treated with immune checkpoint inhibitors. Then we were very, I would say, reluctant, prudent in using IO. It does not seem to be completely confined by the data that we have for the moment. But I think we should probably look very carefully at the IO in this circumstance, and potentially those patients receiving both chemotherapy with the risk of neutropenia and IO may be at higher risk. But for the moment, we did not observe anything. But I told you how we try to protect our patient in postponing some of the treatment. Then for the moment, I don't think that we can have a formal answer. But as you know, the TerraVolt cohort is ongoing. Already more than 60 patients have been put in the cohort, and I think we'll have the answer quite quickly.
Harry Kluger, are you still on?
Yes, I am.
As an immunologist, tell us a little bit about your thoughts of it. Yes, you're on mute. Yeah, we hear you. Tell us a little bit about immunotherapy and the risk of toxicity here, because that's one of your specialty areas of research.
Yeah, so I think that the big answer is that we don't really know, but we're certainly trying to study this. So we've been prospectively collecting bloods on patients who are getting immunotherapy actually for about over a year already at various different time points. And we've actually only enhanced that at this point because we think it's a really important question. So I think nobody really knows why patients with COVID actually fail to clear their virus. whether it's a breakdown of the upper or lower airway, whether they're unable to mount an antibody response, or whether they have instant T cells. So if you try to break all of those down, and it's all theoretical, it is possible that patients who are already on IO early in the course might actually have a better response to virus, just because the innate system, in addition to the adaptive system, is a little bit more activated. But there's a lot of hand waving over here. And there actually was one question over here, is whether we would even consider giving IO as a prophylaxis for patients getting severely ill. And I think we need to lean to our European colleagues to see how many IO patients they had that had severe pneumonitis. And there it might differ by disease type, because for years already we've said that in our field we see very little pneumonitis, whereas the lung cancer team sees a lot of it for a variety of reasons that I won't go into now. So it might be, it's a very complicated answer, but I'd like to hear from the Europeans what the experience has been with IO-treated patients who were exposed to COVID-19.
Yeah, we've lost the two Italian doctors had to leave, but we do have Fabrice, and then maybe Christopher can say a little bit if he's seen anyone in the unit.
I would say that for the moment, we have very few patients treated with immunotherapy. We tried to postpone all of the patients who are, I would say, experiencing a benefit from IO. You know, all of these patients stable for a long time were postponed. Then as we enter in the crisis only 3 weeks ago, for the moment, I cannot tell you, I would say, all those patients will perform, and if, because sometimes they may have been hospitalized in other hospitals, then we are not always aware about that. Then, but we will have, I think, in participating in all these international courts, I think that we will have the answer very quickly. Our Italian colleagues are collecting a lot of cases, and I think that we will have the answer very rapidly. But we are also looking at doing more research on those patients to better understand how the immune system is influenced by the COVID disease.
Okay, actually, maybe what we'll do now, since we're at time, is we'll do a little round robin to end the day, and I'll just ask everyone to prepare, less than a minute. So the lightning round, we'll go around the square here, and ask everyone for one last thought or advice. I think this has been very illuminating to me. We've had a number of disease content experts. We've heard from a number of countries. We're sitting here in New Haven. 4 of us are from New Haven. We're just awaiting the storm. We have a pretty full hospital, and we're making space for any more ICU beds we can have. We're even asking some of our oncologists to work in the ICU now. Not me, but some of the younger ones. So let's go around the horn. Dr. Kumar, thoughts and advice. We have about 200 plus people on the line. Just for the next week, what to think about. Let's unmute yourself.
Most importantly, I would say is widespread testing and low threshold for testing and rapid turnaround. I think that's going to help make all triage decisions really, really effective. The more we can do this, the more effectively we can do this, we can really segregate patients appropriately. So I think that would be the key coming into this week. And we've already ramped up to it. We have a test coming back within 20 hours now, I'd say. But I think it can be better than that. So that's what I'd say.
Thank you. Dr. Burtness.
So I'll just amplify that. I think rapid early testing is really important. In head and neck cancer, we see a lot of patients with fever and cough because they're aspirating, or they have pneumonitis from one of the agents. So our recent move to ambulatory testing I think is really going to help us keep down the number of patients who are in hospital just to be under investigation, or allow us to admit people for aspiration pneumonia and to the non-COVID units. So I think that the sooner you can move to ambulatory testing, the better for your institution.
Okay, now I'm going to turn to Dr. Rubo, and I just tell you, as you unmute, one of our pulmonary fellows here had a baby the other day, and the middle name is Hope. Given what's going on. Hope, thoughts for the next week, what's going on and what we should expect?
I think that the increased use of testing, and I don't mean to repeat what my last two colleagues said, I think there are two big areas, the increased use of testing and how to deal with positive tests in cancer patients, and how we can get around the issue of patients who are symptomatic. You know, before they were symptomatic, they couldn't get tested unless they met certain criteria. Now we've really lowered that threshold so that we can test people more rapidly. Once the patients test positive, however, then we're really faced with patients who are symptomatic from cancer but who can't get treated. So the next thing is having clear guidelines that we all share in terms of when patients can be treated again after they recover. And then lastly, I think that understanding which treatments put our patients at higher risk versus not is really a critical issue. And, you know, for immunotherapy and breast cancer, where you don't have a lot of the lung issues that lung cancer patients have, and they may not be as sick as, say, a melanoma or renal cell patient, we haven't not used combination immunotherapy and chemo because that's our only indication. So I think as we learn more about this from our colleagues in Italy and France, who are unfortunately farther ahead, and then our colleagues in New York, it will really help us a lot, not just for now, but for the future. And then very last thing is people have asked on the chat, how is this going to affect us? One, I think that, you know, I hope we're able to maintain this sense of community that we've developed even greater than what we had before, and without being able to see each other in person from COVID. I mean, it's really been incredible, and I've been just amazed by the commitment and work of all of my colleagues around the United States and around the world in terms of really stepping up to the plate. And I hope that telemedicine survives because I think it's really important.
Right, I would maybe bump into you once a year at some exotic location for a meeting. Now I've seen you twice in 2 weeks and enjoyed it.
Yeah.
Dr. Manley, thank you to everyone who's working in the ICU and is really, truly on the front lines. Any thoughts?
Yeah, so I'd say there's three main things. The first is having adequate PPE. I think that while testing is going to be important in isolating patients who actually have the disease, having adequate PPE for staff members. The second is adequate staffing to prevent burnout and make good decisions for our patients. And then the third is understanding the evolution of disease. You know, we see patients who improve from a ventilatory standpoint, only then to die of cardiac arrest from a rip-roaring myocarditis. And so I think that we need to better understand how the disease progresses in some patients versus others and be able to support them through that.
Thank you. Marianne?
I think that two of the things that we touched on before, one thing is using social distancing in a slightly different way. So some of the efforts we've made are to move our ambulatory clinics out of the main tower, cancer tower, where we now are housing a lot of the ICUs and also the urgent care evaluation clinics for COVID. And so trying to separate out the oncology diagnosis in the ambulatory setting to other satellite settings, and hopefully that will protect them. And I think patients have been very flexible and very understanding, and they are, again, they have the resiliency and they want to be protected as well. So they appreciate that effort. And the other effort in terms of the social distancing is the workforce mobilization and assuring that we're protecting groups of people in the workforce by doing rotating schedules to try to keep people as healthy as possible has been another effort that I think will give us the ability to meet the patient's needs.
Thanks, Marianne. Jack?
I would say that the key point is that I think it's really great what Hope brought up about this does have some constructive parts to it. It has brought together people communicating. We've always felt like this is an international community, but this has really galvanized people in a way that, you know, we are talking from all around the world on a Saturday to reach docs and patients and share every shred of promising information that we have against a common enemy. And I think that, of course, this is really a global challenge, but it has created out of necessity more of a sense of a medical community working together. And I think that it's forced us to be more efficient in our education and telemedicine, and just trying to prioritize, look back at what we need to do and what has been more ritual, what we can do away with, and trying to reassure the patients as well that we are not looking at or at all considering giving up the therapies that really work well. We are really just trying to prioritize the treatments that are most effective and not doing things on an interval that may be artificially rote, more frequent than it needs to be, and having people come in when they can be safely evaluated at home. And so I think these are just applying some kind of lean principles of doing what we need to do and minimizing the ritual aspect to be efficient.
I couldn't agree more. One of our heads of pharmacy said to me, if we could do a telemedicine the day before, clear someone for chemotherapy, then the chemo could be waiting for them when they come in, you know, allowing for less delays and more efficiency, more protocols. Fabrice, so thank you for your patience. You actually have sounded great. Any words of wisdom from France? Are the croissants being served yet?
No, I cannot agree more than what have been said before. I think we are leader in the precision medicine field, and I think it's what we should do for COVID crisis also. We should do individualized quarantine, wearing masks, every patient, every healthcare workers. We should do a molecular quarantine in testing every patient and probably putting at home all of those patients who are positive, but also treating those patients who are negative, because I think it's the only way not for those patients to pay twice, one to the COVID and one to the cancer. And I think it's what we should try to do, and also to better understand in trying to set up specific, I would say, collection of blood collection of the patients we are seeing in our clinic, just in order to better understand how we'll be able to protect them in the future.
Right, I'm going to turn it over to you in a second, Haas, as the last, but I'm about to turn to Harriet, but I'll just give my thought. You're absolutely right, and there are many patients on the line right now. We've got to be the best advocates for our patients. If we do an alternate therapy, it's because it's a good alternate therapy. We have to fight the best we can. There might be limitations to make sure that the best cancer care is given, and I agree with you that there are many patients with cancer. It's not going to go away. We have to be ready to take care of all of them. Harriet, just before we turn to Haas for his thoughts and final words, any last words of advice and thoughts on this problem?
Sure. So a lot of things have already been mentioned, but I'd just like to add to the frequent testing issue. We really need to get a handle on the role of IgG and IgM in determining who is actually post-convalescent and can either come back to work, or in the case of patients who get further therapy. I don't think that's been tested widely enough. The problem with the viral testing is the sensitivity isn't always that good, nor is the specificity. I think also as a research community, pooling resources and continuing with dialogues such as this are incredibly important. And then finally, as caregivers, things that were mentioned before, standing up for our patients who might have prolonged potential for survival, who might be denied care simply because they've got a history of cancer.
Okay, so I want to thank all the panelists, and now I'm going to turn it over to Haas for his thoughts and final remarks.
So first of all, thanks to all of you, all the panelists who volunteered their time on a Saturday morning or afternoon, evening, depending on where you are in the world. We really couldn't have done this without you. I'd like to thank all the participants who submitted questions to help us figure out what is important to you and try to discuss them. And also thank to our colleagues at the Axiom who helped us put all of this together, did all the invitations, and provided a platform for all of us to get together internationally and talk. I echo everything that you guys have said. I cannot add more to what you have all brilliantly expressed in terms of patient care and the needs that we have in Philadelphia as we're getting ready for the COVID wave to hit us. We are learning and we're listening to your experiences, and I think in the long run, hopefully that would just help us take care of our patients a little bit better, just because we are learning from your experiences. I cannot add any more to the need for telemedicine to continue and to be expanded with all the regulatory things that have to go away. And I'm going to say something that beyond the week that I'm going to be looking at, I think the more it's interesting to me that the more we think we've learned, the less we know. A simple virus on its surface, biologically, we've dealt with viruses a lot, seem to have introduced a whole new set of problems and issues and some very interesting questions from a research point of view that I think we're going to be working on for the next few years to try to respond to and hopefully be better prepared and ready in case something like this happens. And again, if you listen to experts, this is going to happen again, unfortunately. So I think there's a lot of lessons here that we can take away and work on so that in the future, if we're faced with something like this, we are much better prepared to handle it. So again, thanks to all of you, and I hope to see you all on the other side of this disaster, and hopefully we can continue to take care of our patients in the most appropriate way from this point on. Thank you.
Thank you, everyone.